Chapter 17 covers respiratory emergencies. As a review, inspiration is an active process. The muscles contract, increasing the size of that thoracic cavity. Intercostal muscles and diaphragm contract. That diaphragm pulls down, acting like that plunger, pulling air in. Expiration, more of a passive process, just laid back. So all the muscles at that point relax, inner thoracic cavity gets smaller, and air flows outward. To determine adequate breathing, observing the rate, rhythm, and quality. Average rate, 12 to 20 breaths a minute for adult, 15 to 30 breaths per minute for a child, and 25 to 50 breaths per minute for an infant. Also looking to make sure that rhythm is regular and that it is an adequate quality. Assessing that tidal volume, making sure they're able to get in a substantial deep breath. On a pediatric note, the structure of an infant and child's airway is a lot different than adults. It's a lot smaller, so it can become more easily obstructed. They got a lot bigger tongues proportionally than adults do, and that trachea is a lot more softer and more flexible than the adults. So if you imagine it as the hose on a vacuum cleaner, how it has rings in it so it doesn't kink, an adult's is like that. The child's is much smaller, so when the head goes forward, they can be much bigger of a kink. Signs of inadequate breathing in an infant is when they start to use any kind of accessory muscles or different kinds of body positioning. They start using nasal flaring, they're grunting, like they're really struggling to get their breath in, they're doing a seesaw breathing, and they've got the intercostal retractions, those muscles in between the ribs sucking in. Generally, once those kids start throwing their head into it, doing the head bob, that's the final stage of that kid trying to compensate to be able to breathe. When it comes time to have to ventilate that patient who isn't adequately breathing on their own, as you breathe, you need to ensure that you see equal rise and fall of the chest each time you squeeze the bag. Ventilation rates, 12 breaths a minute for adults and 20 breaths a minute for infants and children. As I've said, I don't like ranges, so that's about once every 5-6 seconds for adults and once about every 3 seconds for kids. Assessing if you have inadequate ventilations is you may see that pulse rate start to increase or the pulse quality get a lot weaker from build-up air pressure inside from overventilation. Also, if you find decreasing pulse rates in pediatric patients, if you see that pulse rate in that pediatric going down, a very bad sign. So assessing breathing difficulty. That's a patient's subjective perception. To you, it doesn't look like they're having any problems breathing, but to them, this may be the worst moment they've ever had in their entire life. They feel like they're about to die. So they start to get that labor, difficult breathing, the anxiety and distress kicks in, and then that also doesn't help the breathing difficulty any whatsoever. So asking those OPQRST questions tailored to the breathing difficulty patient. Onset, when did it begin? Provocation, what were you doing when all of this started? Were you smoking a cigarette when you started having shortness of breath? Or were you doing something very physically demanding? Quality, do you have a cough? Anything coming up with it? Radiation, do you have pain or discomfort? Anything else going on with the breathing difficulty? Or does it seem to affect anything else? Severity, how does this compare to other times? If you've had breathing difficulty before, is this the worst you've ever had, or is this about the run of the mill? And time, how long have you had this feeling total? So you're going to be observing, checking that altered mental status. As I've said multiple times, that mental status that changes, that is abnormal to what their normal is a very big indicator that something's wrong. Using that unusual body positioning, they're heaving out their chest, they're in a tripod positioning, got their nose up in a sniffing position. Once you see any kind of body work going into it, that's just more effort that they're trying to use to get their breath in. Very bad indicator. So looking for retractions, accessory muscle use, you start to see the muscles that attach to the collarbone and up around the neck straining. See those flared nostrils from a sniffing position. You make a duck face, pursed lips, trying to create their own positive airway pressure inside. And big assessment when you start talking to that patient, how many words can they say in a full sentence? If they can tell you, oh dear Lord, I'm having the worst breathing problems I've ever had my whole entire life, that may not be too bad. But if it's 1-2 word sentences, very big indicator that is very bad breathing. Also looking for skin color, temperature, condition. Are they pale, cyanotic, meaning do you see parts of skin that are blue? Do you see any edema build up around their extremities, most notably the feet? Since that's the furthest part away from the heart, that's where fluid's going to build up first. In sacral edema, meaning fluid around the belly. And do you notice any hypoxia on the monitor? So generally, if you notice any cyanosis, the hypoxia is going to be adjoint to that. During your observations, some other things be very cognitive of, and generally these will stick out like a sore thumb or any kind of advantageous breath sounds. Those heard that you don't even need a stethoscope to hear, such as stridor or the death gurgles, where it sounds like they're choking on chocolate milk. So you'll hear those gurgling sounds, upper airway stuff, the snoring, if they're laid back and that tongue's laying in the position, closing off that upper airway. Stridor, if you hear stridor, it means the upper airway is completely constricted. That'll be a very high, very high pitched sound, or just general coughing. Generally, shortness of breath and coughing are associated. So with auscultation, that is listening for lung sounds on both sides during inspiration and expiration. So you listen on both sides to be able to tell if those lung sounds are the same bilaterally. So we like to hear lung sounds that are clear and equal bilaterally. And the locations you want to assess for auscultation: up here to mid-clavicular line, mid-axillary, and on the posterior side, curved around the shoulder blades. In this area here, one of the best things you need the patient to do is give themselves a big hug. Then it opens up these shoulder blades to let you get in, because you can't hear through bone very well. And then again, on the other mid-axillary side. So sounds you're looking for during auscultation: wheezes is that high-pitched sound that's air trapping, trying to go through those constricted bronchioles. So this is kind of equivalent to trying to let air slowly out of an inflated balloon, and you hear that whistling sound as you're pinching the end of the balloon. That is wheezing from the bronchioles constricting, air movement through that tight space. Crackles, also known as rales, is that bubbling sound heard generally in the lower lobes of the lungs. But if those lungs get full of the fluid, you can hear that bubbling sound everywhere. Rhonchi is a lower pitched, kind of sounds like a rattling, like a rumbling of secretions. It's just a movement of mucus pretty much in those bigger upper airways. But again, you can hear rhonchi in every part of the lungs. In stridor, that's heard without the stethoscope, the high-pitched death scream. If you can walk into a room and hear stridor, your patient's in very bad condition.
There are abnormal breath sounds that you should be familiar with. Snoring, caused by partial obstruction of the upper airway, often caused by the tongue. Stridor, a harsh, high-pitched sound heard on inspiration, is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration. Rhonchi is a rattling sound heard in the larger airways caused by excessive mucus. Rales are a bubbling sound heard in the smaller airways, typically when they fill with fluid, commonly encountered with CHF and pulmonary edema.
So in terms of patient care when dealing with breathing difficulty, first is assuring that they do have adequate self-ventilations. If the breathing is inadequate, you must begin artificial ventilations. So if they're not breathing well, breathe well for them. If the breathing is adequate, supplement with a non-rebreather at 15 liters a minute. So begin with least invasive, go to most invasive depending on their condition. Also, more invasive is continuous positive airway pressure. It's simply blowing oxygen and air continuously at a low pressure into the airway. This keeps the alveoli from collapsing during exhalation. It also can prevent the fluid from shifting into the alveoli from the capillaries that surround those alveoli. So the fluid that's in those alveoli or in the capillaries wrapping around the alveoli, that can end up shifting into the alveoli, causing some major breathing difficulties, that pulmonary edema. This is the CPAP is the same principle as blowing up a balloon. As you blow it up, you hold the pressure and you blow harder. That's the simple process of the CPAP, except it stays at a more constant pressure so you don't make the lung into a true balloon and pop it. Some uses for it, most commonly pulmonary edema. Having that fluid in the lungs will pressurize and shove it back into the vascular space, back into the vessels. Of drowning, asthma and COPD, or just really any kind of respiratory failure. With asthma and COPD, you can also make it go in line with medications to help those asthmatic severe COPDers, and with the drowning, shifting the fluid, same principle as the pulmonary edema. Contraindications for using it though, patient has that severely altered mental status, because with that, if they have an altered mental status, it means they may not be able to maintain their own airway properly. So if a patient doesn't have their own proper airway, the last thing you need to do is continuously push airway pressure into them. Or the patient that has the lack of normal spontaneous respiratory rate. So if you have the patient that's not breathing, or the CPAP is kind of a demand system, it's just going to continue to blow and blow and blow, and then make those lungs just like that balloon and pop them. Also, the inability to sit up or hypotension and shock. The CPAP, as it pushes pressure in, can cause hypotension. Other contraindications include nausea and vomiting, penetrating chest trauma, shock, upper GI bleeding, recent gastric surgery, or conditions preventing a good mass seal. So with nausea and vomiting, you don't want to have vomit in the mouth and then shove that down into the lungs. Chest trauma, increasing that interthoracic chest pressure, having that issues there, say with a popped lung, pneumothorax, those kind of things. You don't want to increase the pressure there. It ties directly, just same as the gastric surgery. You don't want to end up causing any more kind of air pressure that may get into the belly, causing issues with that. And shock, being hypotensive, as you're pushing that pressure in, it can end up causing that vascular space to open a little bit, so it will make hypotension worse. Some side effects of that: hypotension. Like I said, that pressure pushes in, opens up that vascular space on the opposite side of the alveoli. A pneumothorax, popping a lung. So pneumothorax, getting air into the chest cavity from a popped lung. Also increases the risk of aspiration, so if they are vomiting, it can end up shoving it in the lungs. First thing to do when using the CPAP is you need to explain the procedure to the patient. This can be kind of quite a freaky feeling for them as you're about to put a pressurized, tight-fitting mask on their face and a tight band around their head. So they may get a little bit anxious, so take baby steps in applying this. Once you get the mask on, putting the mask on, getting it set up, then get the strap around their head. Just small, slow steps and getting the patient more comfortable, and then reassess and continue to monitor that patient. Monitoring, seeing if you're improving their oxygenation, their ventilations, and still continue checking their blood pressure and their mental status. If they do go unresponsive, depending on the CPAP system you have, if it's a separate mask and hose device, you can leave the mask strapped to the head and grab the bag and attach that to the mask and ventilate the patient that way. If it's a one-piece circuit, you need to remove the entire CPAP system, and then manually ventilate your patient. So we'll talk about some respiratory conditions, some chronic lung diseases. Biggest, most notable one is COPD, chronic obstructive pulmonary disease. This is just a broad category of lung diseases. This is emphysema, chronic bronchitis, black lung, and white lung diseases. Overwhelming, this is the majority of chronic breathing problems you will encounter, and most of these are caused by cigarette smoke. Chronic bronchitis is just the bronchioles being chronically inflamed and when that happens, there's excess mucus produced. So these patients will be coughing, hacking all the time. So the cells that are usually in there to clear away the mucus are unable to do so. These patients are considered blue bloaters, as they will appear a little bit bigger. They'll have a barreled chest where those lung tissues are just gradually inflating. They'll have a big barreled chest, and they're normally hypoxic. So that's why they're called blue bloaters. Emphysema, this is where the alveoli walls break down, and when that happens, it reduces that surface area that the oxygen and everything can produce gas exchanges. So less surface area for the oxygen to come on board and the CO2 to offload. So they'll have a lot of build-up CO2, more so than the chronic bronchitis people. The lungs are going to lose their elasticity, so with that decreasing surface area. These folks are normally considered pink puffers. They'll normally have their pink tone to them, a little bit less hypoxic than the bronchitis patients, and they'll just be taking these like a puffing breath, and they're generally more skinny, frail, because they're doing that puffing and they're burning a lot of energy, so they'll be skinnier, maybe not so much on the fat side. Illustration of a normal versus the chronic bronchitis and emphysema. As you can see here, chronic bronchitis have this excess mucus production all throughout the alveoli. So these patients will be coughing, hacking, trying to get this stuff up all the time, and then this is going to cause the inability to get good oxygen exchange. Whereas emphysema, you've just kind of lost the surface area. So with bronchitis, you got all these rounded pathways in through here, and with emphysema, it's just one large cluster. So a lot less surface area. The little prongs in here are gone. Asthma, most people familiar with that. It does have its often exacerbations. Exacerbation is a term that's commonly used with breathing problems. That exacerbation just means that it's there, but it's just a recurrent condition that has worsened. So having an asthma attack would be an asthma exacerbation. A COPD person who just suddenly started having problems breathing again, a COPD exacerbation. Asthma is generally triggered by such things as allergens, whether it's such things as weeds, dust, dander, pets, things like that can cause those asthmatic exacerbations. So when that happens, the small bronchioles will constrict and there's excess mucus production, so they can be coughing as well. So remember, anytime there's a disease where mucus can be produced, the patient may be coughing. The results in those airway passages get small, practically close, so when they close, that causes the wheezing. That's generally constricts the airflow either on the inhalation or exhalation side. So that's why you need to listen to lung sounds as they inhale and exhale. Pulmonary edema most often occurs from congestive heart failure. It's the #1 leading cause. Other than that is infection, say a sepsis patient, someone who's in septic shock, near drowning, just outside fluid coming to the inside, and major airway diseases such as ARDS, acute respiratory distress syndrome. What that is, pressure in the pulmonary capillaries, the ones that surround alveoli, they build up pressure, and that fluid that's in there will overcome the other kind of pressure that's built up inside the alveoli. So that fluid shifts from the vascular system through the thin barrier of the alveoli and will accumulate in that alveoli. So that grape-like sac cluster is will start to slowly fill up full of fluid. So oxygen and gases don't go well through liquid, so they're not able to oxygenate. So the oxygen will get to the water, but it can't go through it. So the analogy of the alveoli and the capillaries being that harbor, well, the water's overflowing the dam and there's not really much control going on. So the oxygen will get down to the waterfront, can't go through the water to get on the boat that's under the water, being the red blood cell. These patients that are generally dyspneic, having major problems in breathing, so when that happens, they get anxious and they'll have pale and sweaty skin since they're not perfusing and oxygenating well. And then with that respiratory stress comes tachycardia. They'll be hypertensive because a lot of times hypertension's the first precursor into heart disease causing all this. So they have that high blood pressure. They'll be pushing that fluid out of the vascular system into the alveoli. And just overall, everything else that goes into breathing difficulties of different respiratory rates, slow, fast, agonal, and low saturation rates. Common signs and symptoms, the crackles, and sometimes there may be wheezes. So you may hear wheezes in those upper lobes and think it's just COPD or asthma, but if you don't listen to those lower lobes, then you would hear the crackles down there. Whereas crackles are the more dominant sound you need to worry about than wheezes. Also, they may spit up a white frothy sputum. Sometimes it has a pink tinge to it. So pink frothy sputum should lodge in your head knowing that that is associated with congestive heart failure. So if you go in, the patient's having problems breathing and they're spitting up stuff and it's frothy looking, it's pulmonary edema. The fluid that's just fluid that they're spitting up out of their lungs. Treatment for them, number one thing honestly that happens anymore is a CPAP. That fixes a patient who's having respiratory distress with pulmonary edema, who doesn't meet the contraindications, who is within the indications to use it, helps them immensely. Otherwise, high concentration oxygen, keep them still sitting upright. If you lay that patient flat, all that fluid will shift and cover an entire surface of the lung, whereas if they're sitting upright, the fluid is just going to be at the bottom part of their lung, and there's still some surface area to oxygenate. So while the CPAP system's getting ready, put them on 15 liters non-rebreather. Pneumonia is caused by bacteria, viruses, and fungi that end up growing up in the lung tissues. This just results from inhalation of the such things that will end up growing in there, causing inflammation, causing some nasty lung sounds. They'll generally just be short of breath. That's either with or without exertion. They can just be sitting completely still and be short of breath. They'll cough, and the number one indicator with that is a fever. Patient having pneumonia, hypoxic, problems breathing, and they have a fever is generally pneumonia or sepsis. They sometimes may have sharp chest pain or pleuritic, just kind of hurts when they cough or on their sides. Also have headache, pale sweaty skin, fatigue, and confusion depending on how bad it is. And often a big indicator too is when you listen to lung sounds, you may only hear bad lung sounds on one side. Doesn't mean if you hear bad lung sounds on both sides it's not pneumonia, but sometimes it's isolated to a single lung. Treatment for that is mostly supportive care. This is long-term care in a hospital. You've probably heard of younger people having pneumonia and they go to the hospital, maybe even get sent right home with just some medicines. Older folks, this can lead to death. This is a very bad lung disease for those chronic folks. A lot of times it's so bad that they can't come back from this, and all the antibiotics aren't going to fix this. Otherwise, younger population, they just send you home with a steroid and an antibiotic. So on the way to the hospital, basically just supportive care for these folks, oxygenate, keep an eye on them. If they need ventilated, do it. Otherwise, nothing too crazy, no medicines we can give to fix them in a pre-hospital setting. A spontaneous pneumothorax, just as it sounds, a pneumothorax that spontaneously happened with or without reason, just that lung collapsed. The tall, skinny basketball player and smokers, those are the ideal candidates that this happens to. And it does happen. You can watch medical shows. A The good, healthy 19-20-year-old just suddenly is kind of short of breath and developed a spontaneous pneumothorax. Not really much rhyme or reason to it, but there are sometimes underlying issues that go into it. So we'll just have sometimes chest pain, and the big thing, decreased or absent lung sounds on the side of that injury. So if a lung busts, you're not going to hear many lung sounds on that side. So they'll be short of breath if they're only breathing through one lung, and of course they're going to be hypoxic, possibly be cyanotic. So anything that goes with popping a lung, low oxygen levels, cyanosis, tachycardia, the whole rigmarole is going to go with that. Then those spontaneous pneumothoraxes, if they get bad enough, they can develop into a tension pneumothorax, where it's a whole lot of air buildup, shifting everything to one side or the other. Mostly for these patients, just comfort and care and give them oxygen. Because most of the time we get to the hospital, they cut a hole inside their chest and give them a chest tube to get the air out, equalize that pressure back in there. And with being a thoracic injury to the lungs, CPAP is contraindicated. A pulmonary embolism is a blockage in a blood supply to the lungs. So where the capillaries surround the alveoli, there's a clot there. So there won't be any blood flow getting to that alveoli for oxygenation and gas exchange to happen. So this is a perfusion problem, not a ventilation problem. All the airflow will get to all the lobes of the lung, but the oxygen that's in that airflow will not oxygenate. It's not going to cross over into the bloodstream because there's been a dam placed up and the river is completely blocked. Patients just typical short breath stuff, anxiety, coughing, sweaty, pale skin, tachycardia. Biggest indicator, unexplainable hypoxia. They will have clear and equal breath sounds because it's not a ventilation issue. All the air is getting down in there, but they'll be hypoxic. You can put them on 15 liters and it's not going to change anything. This a lot of times can end up being completely fatal. Treatment for a PE, pulmonary embolism, is basically just transport to a definitive care facility, some place that can actually treat this and give them oxygen. Just keep it on and ventilate them if you need to, but just be cautious and get them to a good hospital. Even though it is hard to diagnose in the field, but if you hear clear and equal breath sounds, definitely, and they're hypoxic, they're probably going to have a PE. Big indicators for that is somebody who just had surgery, an elderly patient who is just in a sitting position, because you can develop clots if you're not moving around real well, or somebody who has a history of throwing clots. So you see this patient at their bedside, they're on blood thinners, and they're fevered and hypoxic, and but got good breath sounds. Generally 99% of the time, that's a pulmonary embolism. Epiglottitis, big disease for little kids, most notably. Thinking about medical terminology, that's itis, inflammation of the epiglottic area. So it just causes a swelling around the epiglottis that can end up causing possibly an airway obstruction if it swells enough. They'll have a sore throat, difficult to swallow. So since all that is happening, it's hard to swallow. You can't swallow the saliva that's in your mouth, so they'll have excess drooling. And as little kids, they'll have their head bob forward and just drool running out of their mouth because they can't swallow it. It hurts too bad. So that will be their position of comfort, is upright in that tripod position, letting the drool run out of their mouth. They'll be sick, have that muffled voice. Think about laryngitis, inflammation, swelling in upper airway will cause that odd voice or odd kind of crying sound. Or if it's severe enough, stridor, that inflammation and swelling of that upper airway causing that upper airway obstruction. Basically just keep them calm, comfortable, and oxygenate, and get them to a hospital. It's a severe treatment that needs cared for. These patients, most notably, don't put anything in their mouth that can irritate anything else. If it's already swollen, last thing you need to do is irritate that tissue. Cystic fibrosis is a genetic disease that appears in childhood. This is a chronic ailment. You pick up these patients you're not going to have to diagnose it. They will already know. They'll have a whole bunch of really thick, sticky mucus that just chronically builds up. Really, the only treatment and fix for these patients is lung transplants. So, coughing, large amounts of mucus, and they're going to tell you. They may have blood, it's up in their sputum that they spit up, nausea, extreme weight loss, just, same thing from having a cough, work so hard to breathe, and just everything. Like I said, this is not going to be a field diagnosis. This just may be a type of person you may encounter, so just be ready for the excess mucus. You may have to suction out the mouth, things like that. That caregiver that's with them or family is going to be your best resource. Those family members or caregiver will be the expert on this because they have been around it their entire life of their patient or child or family member, so they're going to know exactly what needs done. So just take them along, let them be your medical command. Viral respiratory infections, we've all heard of those sinus infections, things like that. Generally minor things treated with antibiotics, but those can make the other airway diseases much worse. So those patients who have asthma, COPD, things like that, when they get those respiratory infections, it just escalates and makes those diseases much worse. So it starts with that sore, scratchy throat, that upper airway stuff, nasal passages, your throat, causing sneezing, coughs, fevers, and chills, things that go with just typical kinds of crud and colds and coughs and flus. And then they can be spitting up that green and yellow mucus. So I'd say probably everybody in one time in their life has had an upper airway infection, sinus infections, things like that. And they've probably experienced all these nasty things that go along with it. So some things you can do to fix these breathing problems also. First is the simple thing of prescribed inhaler. This is the meter dose inhaler. So each time you take a puff, it's measured out as an exact dose. So you don't have to measure anything out. Just push down on it. The same dose is administered every time. This is given for patients who experience bronchoconstriction, mostly your COPDers and asthmatics that experience just exacerbations of bronchoconstriction and wheezing. Just a picture of the prescribed inhaler, or more commonly known as the puffer. So before you give the inhaler, which you can assist patients in giving theirs, make sure it's the right patient, make sure that's actually their inhaler, it's the right time to do it, that it is the right medication, that you don't have some other kind of weird inhaler, giving them the right dose, make sure you only squeeze it once in the right route, making sure they're doing all the 5 R's correctly. Check that expiration date on it. That also always goes in with the right time, making sure the medication's in time, and shake it up vigorously, just like a protein shake or whatever kind of cocktails you make. Shake it up, shake it up, shake it up before you give it. So just use the 5 R's, explain to the patient, have them on oxygen. In some areas, you may have to reach medical command to assist the patient with their meter dose inhaler or their puffer. Some of the puffers come with the little arrow chamber on it because simultaneously you're supposed to inhale as you push down on it. So people who may not be that coordinated could use this chamber where the puffer or inhaler sprays into this chamber. Then at your convenience, you can inhale the mist from the chamber. So to administer the inhaler, get the patient comfortable, have them put their lips around the opening, press inhaler at the same time, and coach them to take a deep breath as deep as they can, and tell them to hold that breath. So that time it gives the medication time to seep down in. Also, you can administer nebulizers. Now, not all states will allow you to do this, but in West Virginia, you can give a nebulizer. So if you've ever been around somebody who has asthma or some kind of breathing problems, you've probably seen one of these, where you put a little medication into a container and oxygen blows over it and it creates a mist. So it just continues to flow that aerosolized medication taken in. And generally that's always just the same kind of medications that's in that meter dose inhaler or the puffers. So to do it, you'll just coax the patient Tell them to put their lips around it, take a deep breath as deep as they can, and try to hold it for about 2 or 3 seconds if they can. Just don't make their breathing worse by coaching them to do it. So as they take that deep breath in, that substance, the aerosolized medication, will get deep in their lungs. So as they're holding their breath, it'll get even better. If they are in extremis, which is just a really, really bad case of this, and they need it down in, and they can't take deep breaths or hold their breath whatsoever, you can put this medication in line in a CPAP, and it will shove it down in their lungs much easier for them.